So we are back. Today, this is the episode 8 of this series of Awake Tracheal Intubation. So we shall continue. Now, I am presenting you a case of 40 years old young male patient. 4 years ago, he developed hoarseness in his voice. He noticed that, but there was no obvious reason for it. Moreover, 2 weeks ago, he suffered from dyspnea. Whenever he's trying to do some exercise, he feels that he was unable to breathe. When the patient was evaluated, a laryngeal mass was found. This laryngeal mass is obstructing the airway. It is obstructing the airway to the level of grade 1. So, the excision and biopsy of mass was planned, and we need to proceed accordingly. In the MRI, you can actually see the mass is in the middle of the airway, and it's obstructing very badly, giving us a very small and narrow room to pass or to intubate. So for this kind of patient, normally there are 2 ways to go for. Either is the tracheostomy or other one is the ATI. So here we also choose the ATI. Regarding the topical anesthesia, we have some questions in our mind. The mass is obstructing right in the middle of the airway. So will it affect the application of topical anesthesia of the airway? Anyways, we were successful in giving adequate topical anesthesia following spray as you go method. We have given topical anesthesia by 2% lidocaine solution 3 times in oropharyngeal region, once in the subglottic and supraglottic region. For a good patient comfort, we sedated the patient with IV dexamethasone and IV fentanyl. And for avoiding any kind of cough reflex, we also have given IV lidocaine. Secretion in these kind of patients is very critical, and we should keep that in mind. So for reducing the level of secretion, we also have given IV glycopyrrolate. For this patient, we proceeded through the nasal cavity. Once the first bronchoscope has been successfully reached to the glottic opening, we introduced the second bronchoscope with the ETT intact. The second bronchoscope were introduced orally and was being proceeded accordingly. Now this is the very critical part. The opening has been depending on the breathing of the patient. As the mass was movable, we would be looking forward a chance to proceed forward, and that's what we did. The depth of the bronchoscope was strictly monitored to avoid deep insertion. The ETT was advanced very softly and carefully, not to injure the mass. Once the tip of the ETT was being shown in the bronchoscopic view, the bronchoscope was withdrawn. Following that, the second bronchoscope was also withdrawn. The placement of the ETT was also confirmed by the capnography. The patient had no cough or gagging, and hemodynamics remained stable during the whole procedure. As for the precautions, I have some points. We should clearly assign the roles to each chief operator, like who will be the visualizing through bronchoscope and who will be proceeding for the intubation. This coordination should be kept very, very good. The second point is we should always have a surgical backup for tracheostomy. If something doesn't go according to the plan, we should have a plan B for this. While intubation, we should pay a very, very careful attention to the resistance of the tube tip, because any excessive force in these kind of patients will result in a very, very bad case scenario. The airways is compromised by the mass, and the mass should be avoided as much as we can. So that's all for today. Thank you, and I'll see you next time.